And we're going to have a session now looking at showcasing some of the approaches that have been taken to preventing and managing occupational violence. So welcome back after lunch, and we look forward to an interesting session looking at some of the practical approaches across our health services. We're going to, or I should say welcome to also to our people who are on video. Nice to have you back as well. We're going to start with a presentation on a whole of healthcare response, looking at Peninsula Health in Victoria with Sue Williams, who is the Chief Executive of Peninsula Health. Oh, there you are, Sue. Thank you. So come on up, Sue, and I look forward to your presentation on a whole of healthcare response. Thank you.
Thanks very much, Heather. I had a couple of slides on. Now this is slow, is it? There we go. I had a couple of slides just on some statistics, which I think we've largely covered today, and that is that occupational violence is largely underreported. Most people have experienced some form of occupational violence, and I think verbal violence is something that is underestimated in the health place. This just reinforces some of the other data that was shown earlier, but this is some data that actually shows violence in the healthcare industry. The blue line is Ambulance Victoria, and you can see, as Tony showed earlier, that the incidence of aggression in the Ambulance Victoria has grown significantly. The orange line is the health services. I was surprised to see a dip, but I think that actually represents the underreporting. But you can see that both Ambulance Victoria and health services are much, much higher than the industry norm. I wanted to talk today by concentrating or telling you about Lynn's story, because this was really the catalyst for change at Peninsula Health about 18 months ago. So Lynn's 55, she's an enrolled nurse, and she has worked at Peninsula Health for the last 8 years. She was working on a general medical unit where she was caring for a 25-year-old girl with an acquired brain injury. She was very agitated, significant issues with her behaviour, and she was awaiting a bed at the Alfred ABI unit at Caulfield and was waitlisted to go. Now, because there wasn't a bed available at that ABI unit at Caulfield, staff thought that they had to look after her. They didn't escalate it. And Lynn thought that she had developed a reasonable rapport with this patient. So she offered to look after this patient on a particular day. Subsequent to that, the patient kicked Lynn, she fell over, she hit her head on a wall, ended up having an intracerebral bleed and got transferred to the Alfred Hospital. She was in hospital for 10 days. She could no longer look after her grandchildren. She couldn't drive for 3 months, and she couldn't come back to work for 6 months, and she only really returned to a full 3 days a week about 6 months ago. Now, as a result of that incident, we decided that that sort of violence should never, ever happen again in our health service, and so I wanted to tell you what we did to try and address that. So the first thing that we decided, and it runs along the same theme that Tony was talking about, normalisation of violence in the workplace. We made a decision that no one should come to work and expect to be injured in the workplace. And that was driven by our board, it was driven by the CEO, and it was driven by our executive. And so we took this very seriously. Our board asked us to develop a suite of KPIs which we report to them monthly, and we also had to report on our improvement actions. And like Tony, every time there was a lost time injury related to occupational violence, I got a text message and the relevant executive got a text message, and that still continues today. The other thing that we thought was, it's silly, there's a whole lot of stuff going on out there and we don't want to reinvent the wheel. So how can we learn from organisations both internally within health and externally to health? And so we looked quite broadly at how we could try and develop our strategy to address occupational violence. We set up a steering committee, which I personally chair each month, and that committee comprises myself, relevant members of the executive, a representative from WorkSafe, 2 members from the ANMF, Vic Police, frontline staff, HWA and Ambulance Victoria, and people religiously come to those meetings. And I think one of the reasons why they come to those meetings is we make sure we deliver on actions and we make sure we report back to make sure that those actions are actually making a difference. And I think that's been really important. So our strategy has really involved 6 key areas. The first thing is that we want to raise awareness amongst both staff and the community that occupational violence won't be tolerated in the workplace. The second thing that we did was we looked at environmental controls that we could implement to try and reduce the incidence of occupational violence in our health service and across our health service. We reviewed a range of policies and procedures and standardised those across the health service. We have made training in occupational violence mandatory, and 100% of our staff are now trained in occupational violence. And we developed improved monitoring and reporting. And then the final thing in relation to that, no matter how hard you try to prevent these incidents, they will still occur, and so it's very important to have support mechanisms in place to deal with that. So if we look at staff and community awareness, we've already started our campaign. We started our campaign before the official launch by the government a couple of weeks ago. And we have got television sets in all of our ward areas, and so as staff walk in, we have rolling films about our staff talking about occupational violence and the expected behaviours of both patients and visitors. The other thing that we do is we have outlined in the patient booklet when they get admitted to hospital what those expected behaviours will be, so they know from the outset what we will tolerate and what we won't tolerate. The medical staff were reluctant, but they have now agreed to develop behavioural contracts for patients, and we've actually used those. It's tricky because if the patient's not medically safe to be discharged, you can't really do much about that, but those patients that are close to discharge who are misbehaving or behaving in an inappropriate way, we would discharge. So we recently had a gentleman in his 20s who was a drug addict who had come in with appendicitis. They were watching him to see if he needed an operation, and as soon as they were aware that he didn't need it, he was out. He was discharged by the medical staff, so it does work. How many of you have PACER programs in your health services? You know what PACER programs are? So that's where you send a mental health clinician out with the police force so that you can try and de-escalate before those people come into your health service. We've now introduced a PACER Plus program because one of the significant causes of occupational violence is drug and alcohol. And so if we can send drug and alcohol workers out with either the police, and we're about to do a trial with Ambulance Victoria down at Frankston, if we can send an Ambulance Victoria, an AOD worker out with the ambulance service or out with the police, we can actually de-escalate the situation before they come into your emergency department. And so that seems to be working pretty effectively. The other thing is, as a result of our relationship with Ambulance Victoria and Victoria Police, the relationship is much stronger, and they automatically notify our ED if we're going to have a difficult patient in advance so that we can prepare before those difficult patients come to our emergency department. Now, we've got a very old cruddy building that's 75 years old at Frankston, and our other sites aren't much better, but we have done a number of things to try and improve the environment for patients. And one of the things that we did do, particularly on this ward where Lynn was injured, was we actually converted one of our bedrooms to a quiet room for patients and their family. So one of the things the staff told us in focus groups was there was nowhere for the patient and the family to go, particularly if they were going to have a difficult conversation. So we substituted a bed for a quiet room. The other things that the staff came up with were really simple things that you could do. So one of the things the staff told us is that they often get assaulted when they've got an elderly, confused patient who is wandering around the ward and they're trying to contain them within the ward area. So what we did was we closed the fire doors, and so they open in the event of an emergency, but it meant that the nurse didn't have to follow the patient and try and stop the patient and then get assaulted. And so our assault rates went down really substantially just by doing something simple like that. We also have progressively removed our overhead announcements. So one of the problems is that people are sleep deprived, and there are various codes going on all day long, and so we've certainly tried to move to reduce the number of codes, and we're hoping to become a silent hospital in the next couple of years. We have an aggression management team that comprises 6 people that attend Code Greys. That originally comprised 4 PSAs and 2 security guards. Often those PSAs were women in their 50s, and they were going to attend Code Greys in the emergency department and they were getting injured. So we made the decision that we were going to reconfigure that, and so we've now got 3 big burly security guards and 3 male PSAs on that aggression management team to try and control that. We've also put wearable cameras on their shoulders. We've checked it out legally, and so long as we tell the patient in advance that they may be filmed, there is no problem. You obviously can't wear cameras if you're in bathrooms or in personal areas, but it has been very effective, and anecdotally we are hearing that it certainly helps to de-escalate the situation by wearing those cameras. The other simple thing that we did was we had a look at the number of aggressive incidents in our subacute facilities, and they were going up. And what we found was most of those elderly patients, when they were being transferred to our subacute services, they weren't going till 4, 5 or 6 o'clock at night. So they're elderly, they're confused, they're going to a new environment, and they became aggressive. So we now pre-book all of our patients to be transferred at 9:30 in the morning, so they've got time to orientate themselves to the subacute facility. And we've seen the number of aggressive incidents reduce from about 15 a month to 4 a month, just by that simple control. And the other thing that we've done is we've introduced duress alarms for lone workers. We did have a lone worker out in the community last year who went to attend a patient in his home, and she was attacked by a dog. She nearly lost her leg and spent 6 weeks in hospital, and so we decided that we needed to do something about that as well. So this is the duress alarm that we use. We actually run a call service for elderly patients, so we have a service called MEPACS, which provides a personal alarm call service to 35,000 clients across Victoria. We have 65 people in our call centre that's manned 7 days a week, and we thought, why can't we use that infrastructure to provide a call service to protect our lone workers out in the community? So what we did was we adapted this alarm, and that's about the size of a matchbox, so you can either put it on your belt or you can stick it in your pocket, or you can wear it on your lanyard if you want. And it's got a GPS tracker, so that when you're about to go into a client's home, you can push that button, and within 2 minutes you can speak to an operator on the phone, two-way conversation, but that GPS tracker knows exactly where you are, so that if you push that button, we can respond immediately. All right. Now, because we're an accredited service, we get priority with D24, so we get an immediate police response if something happens. So it's worked very successfully. The other thing, like Tony, is we were very keen to use this because we wanted to prosecute people if they injured our staff. If you have the alarm on, we can actually record that conversation that's going on through that speaker, and that can be used as evidence in court. So we think that's a really powerful thing to do, and a powerful disincentive. We reviewed a whole lot of policies and procedures. One of the things we did very early on was we put an escalation protocol in. So we said to staff, we want you to know that if there's a patient that you don't think that that environment is appropriate for them, that you can escalate it to your manager. If you're still not comfortable, you can escalate it to your chief operating officer, or you can escalate it to the CEO. And we've used that. So we subsequently had another ABI patient that the staff were concerned about. I picked up the phone, rang up the CEO of another health service, and we managed to get that patient moved to a more appropriate environment. I talked about behavioural contracts for difficult patients. We also have not welcome notices for visitors who've been aggressive in the past. So we hand those out to people, and we manage that if we're concerned about behaviour. And the other thing is we've reviewed the timeliness of mental health referrals and assessment, particularly in subacute. So we were finding that there were delays and there were psychotic patients over in our subacute area that were posing a risk to our staff, and we've streamlined those processes. The other big thing is the medical staff are bought into this, and so our medical staff are also attending code greys at our hospital, which is really important. I talked about training, so occupational violence is mandatory for all staff, and we are also rolling out a pilot of the Safe Wards program, and somebody mentioned that earlier. Just so that you know what it is, it's a program that was developed by the NHS, and it was a program developed to train people in de-escalation techniques in mental health services. And I think La Trobe Health Service and Peninsula Health are the first health services internationally to be rolling that out into the acute sector, and the early results are actually very good. And we've also got our risk coordinators, or our occupational violence coordinators, in all areas, including our subacute sites. I wanted to talk a little bit about monitoring and reporting. So this is our data for the last 4 years. The big graph there, the purple graph, are our planned code greys. So we probably have twice the number of code greys that a comparable health service would have. We actually like to have that in place if we're worried. We'd like to be preemptive, and we have a planned code grey if we think the patient is going to be difficult. I can't see the colours on the lines there. Aggression is the yellow, and the respond greys are the green, and the assaults are the red. That's right. So you can see our data up until June. That's just from last Friday, so it's pretty well up to date. We've actually seen a slight decline in our planned code greys, but I think that's because all of our staff have been trained. We've improved our environmental controls, and so people don't feel as if they need to have as many planned code greys. We've also had a reduction in our code greys year on year and a reduction in our staff assaults. What we have seen growth in is the incidence of aggression, and we're really pleased about that because we think that people are actually starting to report those incidents of aggression. We think that's really important. Just to give you a little bit of data, so obviously we look at our lost time injuries pretty closely. We've had 29 occupational violence work cover related claims in the last 3 years, and those claims had an estimated claims cost of just under $2.5 million. Now the impact on our premium this financial year is going to be $1.5 million as a result of that. About half of that is salaries, but the other half is due to the occupational violence incidents. Now, we have done some really good things, but because it's a rolling 3-year average, we're not going to see the benefit for another couple of years. But you can see that we've reduced our lost time injury days from 39 to 4, which is pretty impressive. But the average days lost for those last 3 years for those people that have had an occupational violence incident is about 94 days. So you can see that they've been really serious incidents. And so that's something that we're really focusing on at the moment. Obviously, prevention's key. And any serious injuries will need a graduated return to work. This is just another graph just to show you some additional costs. There are a whole lot of costs associated with aggression, but these are costs associated with behavioural specials. So people in your wards where you're concerned and you've had to book either an extra enrolled nurse or an extra PSA to special that person because you're worried that they're at risk to themselves or they're at risk to others. And we were spending about $120,000 a month just at Frankston Hospital. Just under $1 million this year we are going to spend on behavioural specials. Now it is trending down, and I think that trend will continue because staff are feeling more comfortable that they're trained in de-escalation techniques, and we've improved our environmental controls. But you do need to go back and have a look at it because it's worth the investment to try and reduce the cost of your agency specials for patients with behavioural concerns. So as I said, no matter how hard you try, you will still have some incidents, and so it's important to have the right support services in place. We have a post-incident response staff, we have a post-incident support service that we use. It's actually outsourced, but it's very responsive, and we make sure that they address both the physical and the psychological injuries of any individual that's injured in the workplace. The other thing that we take very seriously is every occupational violence incident we review at a senior executive level every Monday morning, and it's reviewed by the board every quarter because we want to make sure that we learn from those events and we don't have that happen again. And obviously you want to have a detailed return to work plan for those staff who are injured, and we work very closely with the staff to try and get them back. So in summary, occupational violence is a really complex issue, and it needs to be led by the CEO and the board. I totally reiterate what Tony said earlier. It really does need to be led from the top. As said earlier on, it's a multifaceted strategy. There needs to be a clear message led by everybody at the top that no staff member should expect to be injured when they come to work. There needs to be a serious commitment to addressing the underlying issues from both a time and a resource perspective. Don't reinvent the wheel. There's lots of learnings to be had out there, and make sure that you learn from every incident so that it doesn't happen again. The only other thing that I would say is one size doesn't fit all. So don't think that you can just adapt this strategy and just roll it out. You will need to tailor it to your own individual health services. So I might leave it there and open up for questions.
Thank you, Sue, very much. Let me invite questions from the floor or from our video conference participants. Over the back there, thanks.
Hi Sue, Will from Northern Health. I'm really interested in hearing more about the post-incident support program. Is that something that's an internal system, or are you using an external provider for that? And
We use an external provider, just because I think the staff, particularly if they've got a psychological injury, they want it to be discreet and they want it to be separate from the health service. But they're very responsive, and we work very closely with them to try and get each staff member back to work.
Thanks very much, Sue. It's Vikas Wadva from Benalla Health and Eastern. I'm interested to know how you've been able to police and how effective has it been for the not welcome visitors?
It's tricky, but we have done it. So just recently we had a family that were not good. We warned them about their behaviour in the first instance, and we told them that if they didn't continue to behave themselves, we would call the police. So we didn't want to use our security guards, we didn't want to put them at risk. We called the police and they were escorted off the premises, and they were given a not welcome notice as they walked off the premises. But it's difficult. What I would say is don't put your staff in the front line. We've actually made a decision at Peninsula Health that our staff will not be policing the non-smoking policy at our hospital, because I'm not prepared to put my staff or my volunteers at risk.
Christine Kilpatrick from Melbourne Health. Thanks, Sue. Very impressive work. I thought you said medical staff attend code greys.
Yes, that's right.
Can you clarify that?
Yeah, they are. So we've got a particular hotspot in one of our medical units, and the medical staff actually came to the focus groups with the staff, and it was their decision that they would start attending the code greys. And it's actually given them some insight into some of the challenging situations that the nursing staff need to deal with, and it's been really useful in terms of their treatment.
They attend their own ward, is it?
Only their own ward.
Other questions? Anything coming through from... No? I think we might be done. Sue,
Okay.
Thank you very much indeed. There's some very consistent messages there. Thanks, Sue. Well done, and good luck with the continuing implementation of your strategy. Now, we're going to hear from a regional presenter. So Kate Hopner's got a very interesting title for her presentation. When I was a medical student and young doctor, I thought OVA was something to do with the plural of ovum, which was something to do with fertility. But now we have a new acronym in health, which is OVA, Occupational Violence and Aggression. So Kate is going to talk to us about a prevention strategy at the La Trobe Regional Hospital. Thank you, Kate.
I wanted to have a snappy title so that you would be interested. Thanks very much for asking us to present today. Just in terms of, I guess, a bit of context, La Trobe Regional Hospital is the major referral hospital in Traralgon, in Gippsland, 289 beds. We also provide the area mental health service for Gippsland as well, very large service from Phillip Island up to the New South Wales border. So in terms of transfers into LRH, we have between 10 and 12 EDs and urgent care centres that would transfer into our emergency department, so it's good to keep that in terms of context. In 2013, we set up our Occupational Violence and Aggression work group late in the year, and established that with representation from a broad range of stakeholders. So I'm the chair. We also have another person on our executive that's on that committee, and we have a range of staff, frontline staff, union reps, safety, security, clinical staff, our co-directors of the emergency department, both sit on that committee, and representing mental health, allied health, right across the spectrum of services. So we got together and thought, well, what is it that this group is actually going to do? And our main focus was to reduce the impact, the frequency and the impact of occupational violence and aggression in our workplace. So where did we start? We did a lot of thinking, and what we actually wanted to know was, we wanted to know what our staff thought about occupational violence and aggression, and we wanted to know where our high areas of risk were within the organisation as well. So we actually conducted a risk rating using a risk matrix of all of our departments as a starting point, and I'll talk a little bit about that shortly. We also conducted a workplace violence staff assessment survey, and I will focus on that a little bit later as well, but that gave us some really very interesting information around staff perception and what was actually happening in our workforce. Once we got all of that data, we fed back those risk ratings and staff assessment responses to our staff groups and our senior manager forums and created some discussion amongst the broader staff group. We also used a self-assessment tool and looked at the emergency department, which was where we had a lot of our code greys and aggressive incidents. So we actually walked through and did a self-assessment of the environment, policies, procedures and training as well. And of course we looked at all of our incident data, injury rates, codes, our seclusion usage and our restraint usage across the service as well. In terms, we kind of captured that information and then looked at some of the frameworks and evidence that was around. You know, we need to look at good practice, best practice. Sue's mentioned, you know, don't reinvent the wheel, look at what other people are doing. So we went and had a look at a number of things, and we'd been doing quite a bit of work on reducing seclusion and restraint. So we had looked at quite a lot of data in that sense. The Task Force on Violence in Nursing, ANMF plan, the Auditor General's report, a lot of research, literature. But we also looked at the Workplace Violence Prevention Toolkit, which is the Emergency Nurses Association in the United States. So they have a toolkit that they use, and it's got a range of tools in it that we have adopted and adapted in our area. So and I'll talk a little bit more about some of that. So there were the frameworks and evidence that we looked at. This is our initial risk rating for the departments, and the interesting results from some of the areas in terms of how people rated extreme risk, high risk, moderate risk and low risk. And apart from the fact that, I guess, you know, it's not a foolproof kind of risk rating, but what it said to us is there's widespread violence in our workplace. People are experiencing verbal abuse, physical abuse, threats, all across our organisation, so we knew that it was a significant issue. In terms of our staff survey, sorry, that's not the best kind of shot of that in terms of reading it. We sent out a survey that we got through the Emergency Nurses Association Workplace Violence Toolkit, slightly adapted that to our context, and we actually sent that out on SurveyMonkey to all of our staff. And we had 105 staff complete that survey, which we thought was actually not too bad. Out of those 105 returned, 71 of our staff had never attended any workplace violence prevention training, or they hadn't attended it within the last 12 months. So a very big chunk of people hadn't been to any training. Almost 50% of our staff didn't report workplace violence. Again, we know that it gets underreported. And 89% of our staff thought that most violence wasn't reported, which goes with the literature and anecdotally what we see. In that survey, our staff reported that they'd experienced 363 experiences of aggression in that previous year. So either being harassed, sworn at, shouted at, or racially abused. 6 were threatened, and 371 episodes of physical aggression, whether it be kicking, biting, hair pulling, scratching, being pushed. So our staff are telling us anonymously in a survey that this is going on, but it's not being reported. The majority of our staff wanted training in how to talk to people and de-escalate and negotiate and try to work with people to recognise early warning signs and manage aggression, which goes, I guess, without saying, because most of our staff hadn't actually had any training, and that's what they wanted. They did talk about what they thought were the effective ways of controlling aggression or managing people with aggression, and there was a lot of feedback around having person-centred care models, having really good emergency codes. Mental health and alcohol and drug issues came up as a huge factor, which we know, and having really good de-escalation training. So then after that, we got together as our work group and we came up with our occupational violence and aggression improvement plan. So this is our current plan, and we review this annually, and we review it at each meeting when we meet and go through all of our interventions. So that's just a snapshot of the plan. It's got 3 strategies. I've just shown you the first page there. One is to raise awareness across our staff group, but also our local community as well. The second strategy is building knowledge, competency and skills. And then the third is responding and taking action to create a safe environment. So there's a number of key actions and interventions underneath that those action plan strategies. I'm going to, reinforce what Sue said earlier around having board oversight and CEO and executive involvement. You can't make these things happen if you don't have your board and your CEO and your executive engaged and leading from the front. And that's where our program sits. We have oversight to the board. I report to the board monthly in my report. We have executive buy-in. We have our managers buying in. I often hear that, as I talk to different groups, that managers don't care or managers aren't involved. Well, I think that there's evidence that there's a lot of management involvement in a lot of occupational violence and aggression reduction programs, and it's the same for us. We have very senior management buy-in and our executive and board as well. We've got managers on our work group. We of course have occupational violence on our risk register, so it's a strategic risk that we review and monitor. And we have the overwork group reports through to the Occ Health and Safety Committee, quality committees and to the board ultimately. One of the first things we did was actually change our policy in terms of occupational violence and aggression. We had the old zero tolerance, we'll have zero tolerance policy, and we reviewed that and we wanted to make that focused more on setting a high level of governance, but giving a high level of advice to our staff around how to manage occupational violence and aggression. So again, this has come from the research literature and looking at other programs that have happened internationally, and we use the STAMP model. I hope you can read that. So our policy reflects the STAMP model, our training reflects the STAMP model, and that's a card that we all have on our ID badges to prompt, to get people thinking and reinforcing what they're learning in the training. So the STAMP model is basically around recognising cues for violence and teaching staff how to recognise those cues and then how to respond. So that's how we're focusing our training and setting our policy framework. Prevention comes first. In terms of prevention, and I don't want to kind of keep repeating what Sue said, but we do a lot of the same things in terms of really looking at our data and our incidents and what's happening and really thinking around how do we identify themes, problems in systems, gaps to actually make changes. So we have made a whole lot of changes to things like alerts policies, home visit policy. We review all of the themes from all of our codes and incidents, and that happens with the overwork group. We implemented security roles into the acute mental health unit. So previously they just kind of roamed through, did a check and moved out. But when we analysed our data, we found that most of our code greys were happening in our acute psychiatric unit after hours. So we have put 7-day-a-week security coverage in our acute psychiatric unit on an afternoon shift. And we trained those staff, in addition to their security training, they were trained in de-escalation techniques, suicide intervention, mental health first aid and the safe wards. So the focus of their role is around being there constantly engaging, de-escalating, and that's proved to be a very successful intervention. The safe wards rollout, which we've implemented in our acute aged unit, our adult unit and our secure extended care unit, and we're having discussions around rolling that out and planning for a rollout in our critical care unit who have high rates of aggression. So the safe wards, developed by Len Bowers in the UK, and he basically has 20 odd years of research in acute psychiatric units and was able to identify all the areas of flashpoints where the conflict would be created, and then we would, as nurses, come in and do some sort of containing response, so whether that's medication or seclusion or restraint, and that's where people get injured. So the safe wards contains 10 modules, evidence-based, and it's around identifying flashpoints across staffing, environment, consumers, policies. And the whole purpose of the Safe Wards model is to reduce that conflict and containment so that you're reducing aggression and then you're reducing those restrictive interventions. And we've worked with Peninsula and another 7 units that piloted that across the state. And there's a statewide evaluation of that shows that it is reducing rates of aggression and reducing rates of restrictive interventions. So a good evidence-based model that has potential to lift some of that work into general settings, and there's quite a potential for that to make some improvements. Our cognition work group, we implemented a delirium pathway. We found that we had a lot of people presenting in a delirium and becoming aggressive. So evidence-based delirium pathway implemented. Alcohol and other drug strategies were quite important for us. And as I mentioned, we have quite a number of emergency departments that send clients to our emergency department in Traralgon, and a lot of those people will have mental health and alcohol and drug issues. So we found people were presenting 2 hours away in Bairnsdale, intoxicated with ice. They were being put in an ambulance, restrained and sent to Traralgon. No treatment, all hell broke loose basically when they get to the emergency department. So early intervention is really, really critical. It's interested to hear your role around sending AOD workers out with the police. Significantly important that we actually do some interventions in that area. We did a whole body of work across our region and trained about 350 staff in other acute hospitals, EDs, emergency department physicians, GPs, quite a whole lot of people around ICE, how to manage people who present with ICE, sedation algorithms and treatment interventions so that those staff feel more confident and competent to manage that at the point that the person presents rather than waiting and the risk then escalating by the time they come into the emergency department. We also implemented an alcohol and drug nurse practitioner in the emergency department in Traralgon, and that has been a fantastic initiative in terms of not just education and support for the workforce in the emergency department, but that high-level specialist early intervention to manage people who are presenting with alcohol and drug use. And we're seeing some really good outcomes there. We also have things like security escorts to cars after hours for our staff so that there's safety after hours when they're leaving the premises. We developed a new policy with Bass Coast down in Wonthaggi, particularly around people who exhibit extreme violence and aggression when they present. And we've put a policy together with Bass Coast Ambulance Victoria, police and ourselves to actually manage people in the police cells with us all presenting there and managing that risk rather than bringing the person into the emergency department where things were escalating. So that's a new intervention that we've got in place. Peninsula Health has a PACER. We have a MAPPER, which is mental health and police response. So the same process. We have 2 sites in Wonthaggi and one in Morwell. Mental health clinicians on site. They work from the police department and they provide specific mental health support out in the community. And that has seen a reduction in codes. We've seen a reduction in transfers into our emergency department. We've seen reduction in code greys, so that reduces the risk. So that's a really good program that's had some really good outcomes. We also have emergency service liaison committees. So we meet every 6 weeks with our Ambulance Victoria, police, emergency department, security across the region. So all of the emergency departments across the region. We've got really strong relationships with those acute hospitals. And that is a place where we will review incidents, we'll look at high-risk patients, so people that are presenting quite frequently and posing a risk to all services. We'll put in place management plans to manage that risk. And we do a lot of joint training and development of policies, and so we often have police, ambulance, mental health staff, ED staff in training together, learning the same thing, so we have a consistent approach to training. And I think that for us in a regional area, that collaboration and that regional role and the links that we have with our emergency departments and police and ambulance, the relationship there is absolutely critical to the work that we do. In terms of training, few acronyms there. DEEP, so that's our de-escalation, engagement and prevention training, which is mandatory for all of our staff. That's online mandatory training. And then our higher risk areas, so our emergency department, psychiatric units, they'll do a face-to-face training as well. We have a restraint leader training, so if you are the person in charge of leading that restraint, there's particular training for that team and particular training for the Code Grey team. We have a psychiatrist and a psychiatry registrar on our Code Grey team, and that is always led by the senior mental health clinician on duty, so it's a clinical-led response, and we have security support as well and medical support. Of course, we run our Safe Wards training regularly, and that's mandatory for anyone that works in any of our inpatient units. And we have regular and consistent alcohol and other drug training and alcohol and other drug practitioners within the high risk areas to actually provide that supervision and coaching so that you don't just walk into training, learn the skills and then walk out and aren't able to implement. So we need to support that as well. Oh, there we go. In terms of responses to occupational violence and aggression and some environmental controls, we have our Code Grey and Code Black emergency procedures, a whole range of duress alarm systems and closed circuit TV systems. We do have a post-incident response for staff as well. So we have our employee assistance program that people are referred to, but we also have an internal post-incident response where we work with our managers to support staff individually, provide some watchful waiting and care in terms of how that person responds to that incident. All of our assaults and property damage are reported to the police, and that's something that we're very strict about. We also complete a Haddon matrix at each code, which I'll talk a little bit about later, which is part of the toolkit that the workplace violence toolkit in the emergency nurses have. So that gives us quite a bit of data. In terms of reporting, each area has what we call the knowing how we are doing board. So we demonstrate all of our quality and risk activities and celebrate the good work that we do, and we put a lot of data on that so that visitors, patients, staff can see the data. So we have a monthly, what we call the over dashboard, and we put all of the information around codes, injuries, restraints, seclusions, those sorts of things on that reporting. We then report up to the Occ Health and Safety Committee through the over group. We send out regular updates to all of our staff, and we have an over update at all of our senior management and staff forums. And we have quite a complex database that captures all of the restrictive interventions across the organisation. Investigations. So all our over incidents have to have an initial investigation within 24 hours. We know that that's the best way that we can actually get in early, investigate and make sure that we put in anything that will prevent those incidents happening again. Everything's documented on Riskman. We do critical incident reviews for occupational violence incidents. We analyse the themes of our Haddon matrix, and everything gets reported to our occupational violence and assessment work group. Just in terms of some examples, this is our Code Grey data from 2016. So we were at about 700 incidents of Code Greys in 2014, and we're down to around 350 last year. The red one is the silent Code Grey, and the blue is the Code Grey. So trending down, but we would like to probably see more use of the silent Code Grey in terms of planning and training, that people are feeling more confident to manage those. So we're still tracking our data quite intensively. That's just an example of some of our restraint data that we report on monthly to our units. And this, you probably can't see that very well, this is the Haddon matrix. So I'm not sure if anyone has looked at the workplace toolkit through the Emergency Nurses Association, but they use the Haddon matrix. It's used quite broadly, but it basically is used to identify factors that contribute to workplace violence. So looking at environmental factors, the person who's perpetrating the violence and the staff that are responding or working with the person. And then you think about a whole range of characteristics that are present before, during and after the incident, and it gives you a way of actually analysing the theme. So every code grey that happens, the Haddon matrix is completed by the senior person on duty, and then all of those are reviewed at our over meeting, and we look at all of the themes, and then we identify issues that need to be addressed. A lot of the time, the issues are around staff training, and sometimes systems issues and policy issues. So that's been a really good process for us to look at what our themes are in terms of OVA, and then how do we actually address them. Next steps. So where to from here? It is about commitment and leadership, and I think all of this work needs to be driven from boards, CEOs, executives, senior staff. We need to be all actively engaged in conducting this work. There's some good evidence and interventions from overseas and in other hospitals, so not one size doesn't fit all, and don't reinvent the wheel. There's lots of great things that you can take from other organisations to fit your own organisation and adapt that. Where we're heading next, we are going to look at conducting a over gap analysis, so a prevention of violence in healthcare audit tool that we've got out of the US, and it's quite comprehensive, so we're going to trial that in our organisation and look further to see where our next lot of gaps are, and start conducting that as an annual audit. We're going to repeat our staff survey and see that in the last few years if we've made changes, and if the staff perceive that we have actually made some changes, and really their experience of the work that's happened. We're also going to look at developing a broader people safety strategy, so not just about occupational violence or incidents of violence, but things around psychological safety, mental health and wellbeing, bullying and harassment, and look at how do we approach safety for our staff within the broader organisational context. We'll develop some new KPIs and look at expanding those in terms of reporting, and looking for innovation. So we've got a really great committed bunch of people in our work group, a very engaged board and executive, and we're really looking at ways to be more innovative and learn from others to make more of an impact. And I think that's kind of the message, is it's complex, it's multifactorial, and there's no one solution, but I think with good leadership and commitment and the ability to innovate, we'll certainly see some improvements in this area. And that is the end for me. Thank you. Happy to take any questions.
Thank you, Kate. Can I invite questions from the floor or from our video conferencing participants? Anything coming through there? No? Okay. They are there though, aren't they? Yes, good. Does anyone have any questions of the experiences from LRH that Kate's presented? It was very comprehensive. We've got one. Yes, over there. Thank you.
Thank you. Mary Whelan from Bass Coast. The MAPA project is working really well for us, as you've said. I'm interested in the, we know the traditional first aid training that people do in the community. I believe, but I haven't seen it, there is first aid training in mental health.
Yes.
Are you able to speak a bit about that and see where it might fit in as a start, maybe for community groups or services?
Yeah. I think that one of the difficulties is if you break a leg or you get a snake bite or something happens, someone will know how to give you first aid. If you have a mental health crisis, often people don't know what to say or how to manage that. And I think there's definitely a role for mental health first aid to play in early intervention and actually getting people into services earlier. So I think it's one component that can work. We've done some mental health first aid training across all of our manager group and our HR department, but we run it a lot for community groups as well. And the feedback is always fantastic that, why didn't I do this earlier? I would have known what to do. So there's definitely a role for first aid training in early intervention. Absolutely. Yeah.
Thanks, Kate. Any other questions?
No.
Okay, thank you, Kate,
Thanks.
very much for sharing that with us. Please thank Kate for her contribution. And we're going to move on to hear about, it's been mentioned a couple of times during the day actually, the issue of supporting people following an episode of occupational violence. So I'd like to welcome Professor David Forbes. David is the Director of the Phoenix Australia Centre for Post-Traumatic Mental Health, and he's also Deputy Head in the Department of Psychiatry at the University of Melbourne. He's going to talk to us about best practice support following occupational violence. And there's stairs over there. If you take the safe way. Thank you.
I think about 5 years ago I'd have navigated that without any problems, but I think that's not the case now, so thank you. Look, thank you very much for inviting me to speak today. So, and I love the question around mental health in terms of how do we provide mental health support, and that's a lovely segue really into this presentation. So just a little bit about Phoenix Australia. So I'm the director, as mentioned, of Phoenix Australia. We're a not-for-profit independent entity attached to Department of Psychiatry at Melbourne University. Our mission really is around supporting individuals, organisations and communities responding to the mental health effects of trauma. And we do so through policy and service development work. So we work with agencies and organisations around best practice policies and practice relating to the mental health effects of trauma and supporting people through research and evaluation, and also through training and education. So what I was going to go through today was a little bit about occupational violence, the nature and its incidents, but having seen all the presentations or some of the presentations before, I'll skip through that pretty quickly. That's something that's been covered ad nauseum by the sound of it. You're right across that. But talk a little bit about what are the mental health impacts, what are some of the factors that influence the likelihood and severity of responses, and what are some of the trajectories we see in people who have been affected from a mental health perspective. And then what does that mean around best practice approach to trauma management? So just, as I say, look, given the time I've got, I'll kind of whiz through this first part pretty quickly. Understood that when we talk about occupational violence, we're talking about physical acts, we're talking about verbal acts, we're talking about intimidation and threat. And it can occur in the hands of patients, their families, and of course, potentially also co-workers. And again, I don't need to tell this group around the prevalence of occupational violence in health and health-related industries in relation to, and if anyone wants these, I'll whiz through this quickly. If anyone wants the citations, I can provide them afterwards. Just in relation to what we know it affect in relation to nurses, midwives, personal carers, into ED, doctors and nurses, in terms of aged care nurses, GPs, ambulance officers, mental health workers, and social workers. So we're in no doubt about the prevalence of occupational violence across the health industry. But there's some things we need to think about when we think about what are some of the factors that ramp up the impact, the mental health impact and emotional consequences of exposure. So one is the severity of it. So there's no doubt the degree to which the person feels the likelihood of being injured and the severity of that injury. So there's a severity index in relation to the exposure. But the other is there's also a dose effect, which is there is an issue about how many times, the repetition of threat, the ongoing nature of threat, that there is a dose effect in terms of what that means in terms of its mental health consequence. Sorry, let's jumped ahead. Yep. I've jumped ahead of that, so my apologies. So there's a dose effect in relation to the exposure. The other part is the issue about the types of exposures. Often we think particularly around physical threats, but what we often see, particularly when it comes to gender-related occupational violence, racial-related occupational violence, is the verbal content, which is the sense that for physical threat, you've got some skills about how do I position myself, how do I avoid this, but with verbal violence and with verbal insults and threats and taunting, it can often be difficult for staff members to know how do they position themselves to avoid it and how they manage the elaboration of it. The other part is the level of predictability and controllability. This is something we'll find across the trauma space, which is, aside from the nature of the threat itself, the degree to which it feels like it comes out of the blue, it feels unpredictable, and the degree to which it's controllable. I mean, thinking about our lives outside of the workspace, when you're watching TV at home, the degree to which someone runs through your back window and threatens you at home compared to walking down the dark alley at night in an area that you know is potentially dangerous. So the issue of predictability is critical. And then we bring that to the workplace. The degree to which you can anticipate a threat makes a big difference to the degree to which what its emotional consequences are. Obviously, it makes a difference to how you might manage it, but even aside from how you might manage it, it makes a difference to its impact. And it comes back to the training, I think that, Tony, you were talking about in relation to detecting cues, in relation to be able to detect threat. That's not only important in terms of its influence on how you might manage the threat, it actually has a difference in terms of a likelihood of the mental health consequence of that as well. The other issue is controllability, which is the degree to which the person feels like they've got the skills to manage that threat. And in that context as well, feeling like you've actually got those de-escalation skills that everybody's been talking about is, again, not only a way of being able to manage the actual exposures, but it influences what the psychological consequences are likely to be. So even giving the same event, feeling like, one, it was less predictable, and two, I had felt like I had some skills to control it, influences some of those outcomes. And so what are some of those outcomes that we talk about? So certainly when we think about outcomes of critical incidents or trauma, we often kind of jump and we think about the most extreme kind of post-traumatic stress disorder, and we think about post-traumatic stress disorder because it's got post-traumatic in the title. But probably important to say when it comes to mental health outcomes, there's a broad array of issues that people might experience just in terms of general emotional responses, and before we even get to kind of more frank psychological disorders or psychiatric disorders, general sense about guilt, shame, feeling of humiliation, powerlessness, degradation, feelings of anger, but also being more, when we start to think about conditions specifically, things like post-incident or post-traumatic depression, other anxiety disorders, alcohol-related problems are as common as post-traumatic stress disorder. So when we think about the likelihood of if something does escalate to the point that it generates into a mental health problem, a depression or anxiety problem is just as common as PTSD. And we often see the consequences also in terms of work-related behaviours, avoidance of patients, absenteeism, sick leave, and also potentially the desire to leave the profession. What we might see immediately are things that go across the different methods of degrees of expression. So physical problems, heart racing, sleep problems, aches and pains, stomach aches, changes in appetite, thinking problems, memories intruding of the event, as well as concentration problems, feelings of fear, guilt and anger, relationship problems, feeling levels of distance in relationships, level of conflicts with others potentially, with the patients or in the workplace or with family members, and general sense of loss of interest and social withdrawal. Probably important to say though is that one, not everybody and most don't develop long-term mental health problems in the aftermath of these exposures, but we see very predictable different trajectories. So it comes back to the issue about one size doesn't fit all. That is a critical issue here, which is what we see is 4 common different trajectories. And most of them might have that previous slide, which to say, physical reactions, emotional reactions in the immediate term. That doesn't necessarily change what these different trajectories are. And this is kind of a functioning trajectory. For some people, that yellow resistant line is clear. They've been through this event. They might feel emotionally affected temporarily, but they're able to function, they're able to persist. And we don't see significant changes in their role functioning. Historically, there was an assumption that everyone who was exposed would develop a problem of some kind. We know the significant number of people actually are resistant to and manage to be able to deal with some of these events. When we talk about the recovery trajectory, I'm not sure if this has got a... It's too far. There we go. Purple? Yeah, it's just a bit far, that's all. So the purple trajectory, which is some people are knocked about in the immediate aftermath or in the days and weeks afterwards, but then bounce back. For some people, that blue line is their trajectory, which is they're okay and they travel well in the short to medium term. and then there's a patient that looks like that patient that assaulted them, or there's an event or a presentation type that feels like that presentation type, and that can trigger a delayed reaction. And for some, they're affected, and we talk about the persistent line, that in fact they're affected in terms of their functioning, and that feeling of being affected and the degree to which there's an impairment in functioning, that continues. So what we see is a great heterogeneity, even for people who present rather similarly in the immediate aftermath, in terms of where things go for them afterwards. When we think about those risk factors, we think about what might influence those different trajectories. So this becomes really important for us in terms of what this means for what we do. So one is there's what characteristics they might bring into the event, whether it's a history around exposure or a history around mental health problems or the degree of physical health problems they might carry, or indeed the issue about pre-existing social support. So they're the before factors, the pre-existing risk factors. There's those that occur during the event, which is the nature of the event itself, the predictability and controllability, which we just spoke about, and also the extent of their reactions to it. In terms of those reactions I described before, how severe are those reactions in the immediate sense? And the more severe, the bigger the risk. But critically, it's what happens afterwards, which is how they're supported afterwards, and what other stressful life experiences they might go through in the next 3 to 6 months that follow. But the one thing that I guess really kind of brings this home to us, there have been two kind of large meta-analyses that have looked at people in the aftermath of traumatic incidents. This isn't necessarily just occupational violence. And what that comes out clearly around, and so these figures on the right-hand side are effect sizes, so magnitudes of clinical effect. And despite trauma severity and besides some of the factors that people brought into the event, the biggest predictors we have in terms of what influence those trajectories that we saw before are what are the supports that they experience post-event and other life stresses. So while we can't affect what people bring into an event, and sometimes we can talk about preventing the incident itself, which we've heard a lot about today, should that incident occur, the things that are the biggest factors in influencing their trajectory afterwards, the biggest factors are the factors that are within our control around the support they get afterwards and what other stresses they might be experiencing. So number 1 and 2 in terms of the prediction across studies were these factors that are actually within our control organisationally. And if we're thinking about what intervention means, I'll talk a little bit about, we heard in the previous question issue about mental health first aid. I'll talk a little bit about what we call psychological first aid and a little bit about the difference. But the principles of early support really are these. And while we're talking about psychological first aid in terms of it's this but not this, in terms of detail, these are the principles that we need to keep in our mind, because that's the horizon we need to keep focusing on. When we're wondering about what do I do to support staff, if we're doing things that hit these 5 key points, we know we're going in the right direction. So anything that supports some restabilisation around safety, anything that promotes a de-escalation of stress and arousal and anxiety that promotes calm, anything we can do to promote self-efficacy and a sense of control again, anything we can do to facilitate social connectedness within the workplace and out of the workplace, and anything we can do to engender hope. That if we keep our eyes and minds on these 5 key principles, we're heading in the right direction. The question before was relating to the issue about mental health first aid. Within the trauma space, we talk about the issue about psychological first aid. And the difference really is mental health first aid is around identification and responding to mental health more broadly across the workplace. When we think about psychological first aid, it's usually in preparation for or response to a particular event itself. So in this space, in the pre-post incident space, we use the term psychological first aid. And it is an evidence-informed, not yet evidence-based, but evidence-informed, which is that the principles it uses are drawn from the evidence we have for these core interventions across the rest of mental health. So it's an evidence-informed and flexible approach to helping people after a critical incident. It's focused on practical support and it's focused on promoting emotional support. And it's really intended to be used in that immediate and short-term aftermath, in the aftermath of an event. And it's designed to be as simple and practical as possible, and critically is structured so it can be integrated within administrative and reporting requirements within organisations, something that can be easily taken up by staff, supervisors, managers, colleagues, peers within an organisational context. What it's not And this is true for mental health first aid as well. It's not really something that only professionals can do. This is something that non-clinical managers and supervisors with interpersonal skills are able to provide. It's not a formal assessment. It's not the provision of counselling, and it's not asking people to talk in detail about their traumatic experiences or the critical incidents from a mental health perspective. You may well do an operational review about the incident, but it's not about taking people through the details of the incident. And it's not about pressuring people to talk to you. And what it's not also is psychological debriefing. There was probably a time, it's getting on a bit now, but probably about 15 years ago when psychological debriefing was the expected response to a critical event, which is with the underlying principle that if someone's exposed to a critical event, be it violence or otherwise, it's threatened them, they need to be able to process that in detail. They need to be talking it through in detail, either as individual or as part of a group, and process what happened, how they felt about it, what the images were, what the sounds were. So currently psychological debriefing is not recommended in international guidelines, and we developed the Australian guidelines for the response to trauma, and so currently neither in Australian guidelines nor international guidelines we currently recommend psychological debriefing. Part of the reason for that is that there isn't really evidence that it prevents the development of mental health problems, and it also assumes that everyone's in the same place, which is for some people what they do want to do is talk about it, and that's great, and that's in fact what we're trying to facilitate. Whether it's with staff, whether it's with colleagues and friends, whether it's with their loved ones at home, some people want to talk about it, but they also want to choose who they want to talk about it with and when they want to talk about it. For some people, the last thing they want to do is be able to talk about it right there and then, for a whole range of reasons. One, that's their style, that they prefer just to get back in the driver's seat, get a sense of control back, and when they've got that sense of control back, that's when they want to process it, and they'll choose who they want to talk about it with at the time. And for some people, they're hanging on by their fingernails. They're just hanging in there in terms of managing, dealing emotionally with this event, and the last thing they want to do is be taken into it in a process that they feel like they haven't got control of. The one thing that we want to try and re-establish is that sense of control back again. So in the absence, recommending against psychological debriefing, we recommend, and our colleagues internationally recommend, psychological first aid. And what that is really around simple strategies for helping people cope with distress. It's practical assistance, providing information with what they might expect and how they might manage that. It's helping them connect with other people, loved ones, other social supports. It's providing that supervisor support. Kate, I think, was talking about in her presentation about staff being trained with how do you talk to someone after they've been exposed, how do you support them. When we talk about those trajectories before, and that social support is one of the key factors, I can't count the number of patients that I've had, nurse patients, who hold almost reified in their head the things that their supervisor said to them in the aftermath of those events. And that's really what defined the way in which they processed their event, the way that they processed how the organisation did or didn't support them, their own level of guilt in terms of what happened and why. You know, those critical moments of within organisation support in terms of what does your supervisor say to you in the aftermath of these incidents, and providing some training along those lines. I've heard Kate mention about watchful waiting, which is the idea about being able to then observe how people go then over the course of the next days and weeks. You know, we know our own staff well. We know what's characteristic and what's not characteristic. We know when they're less chatty than usual. We know when they're a little bit more socially isolated than usual. Psychological first aid, in addition to what to say and how to support and how to de-escalate some of the anxiety, is also around what to look for and how to support that, and to gently be able to address that when it presents. And critically then be able to triage people into the kind of evidence-based practices and evidence support if it looks like they're not recovering naturally. One thing about that trajectory slide is the vast majority of people recover in the aftermath of these events using support from within the organisation and using their own strategies. But should people continue to experience difficulties, then triaging them into what would be evidence-based treatment. So these are kind of the Australian guidelines for the treatment of PTSD, if that's what it is, and we're clear if that's what it is in this particular circumstances. But we have evidence-based treatments for PTSD, for depression, for anxiety problems, in relation to ensuring that whatever help our organisation, if it is responsible for contracting and purchasing clinical services to support staff who have been injured, psychologically injured, that we're pretty confident that what we're buying and what we're purchasing is evidence-based responses to support our staff. And naturally enough, anything we do in the incident space is embedded then in an overall workplace prevention and support program in the context of an overall approach to mental health, around mental health strategies and clear management actions that support overall good mental health within the workplace. Thank you very much.
Thank you, David. That's that interesting presentation. Can I again invite questions? We've talked to, yes, Will, thank you. There's a microphone just coming across, I think.
Thanks, David. I'm keen to hear about the support that's provided to the staff that are providing that psychological first aid assistance. Is there supervision for them to help them as being those support people?
Yeah, so there is. So there's kind of practices that people can be trained in to provide that support at the management and supervisory end of things. Also training for colleagues about how best to support each other, what to look out for your work colleagues when they seem like they're not quite themselves in the aftermath of an incident, and match with how to look after yourself at the same time. So yeah, there's kind of training and support that's available through us or others really around the country about how best to train members of organisations to look after their own in the aftermath of these events. Yeah.
So your organisation actually goes in and delivers training, or in the health sector?
We can and do, as do others. Yeah.
Good. Yes, Christine.
I'm just interested, you know, when we have events, you know, Burke Street incident, all these sorts of events, and there always seems to be a flurry of psychologists that there for everyone. I'm just interested, is that psychological debriefing or is that psychological first aid? That's my first question to you. And the other is you said something about, you've got to be careful what the supervisor might say, and I can imagine often people do dramatise some of these, over-dramatise these things. Can you just give me a hint about what you mean? What might they say that could make things worse? Or what would they say which won't make things worse?
Okay. I'll do it the first one first. So whether it's psychological debriefing or not in terms of the Burke Street flurry of psychologists, depends on what they're doing, rather than the fact that they're psychologists there. So the critical part is, you know, are they pulling people up and saying, tell me about what happened, tell me about your reactions to it, what were you thinking, what were you feeling? So if they're doing that kind of thing in an unstructured or structured way, psychological debriefing, and would say we shouldn't be doing that. We would probably be arguing that we don't necessarily need a flurry of psychologists to descend on Burke Street as well, really, which is that to say that psychological first aid and support and monitoring and providing people with a general emotional and practical support in the aftermath of an event like that isn't the purview of the mental health profession necessarily. That's not to say they can't do it, but you don't need to be one. And one of the things I even remember from Port Arthur, where there were more counsellors and psychologists down there, there were disaster survivors. So really important, I think, is from a mental health perspective that we, as mental health professionals, position ourselves where we can best add value and not to pathologise something before it needs to be.
But do people know
Hmm.
People send them in, I'm sure, thinking they're doing the right thing.
Yeah.
I'm sure the Department of Health would want to do with that. I don't know, police, I don't know. But I mean, what you say makes enormous sense to me. There's a famous line in Crocodile Dundee where he says, don't you have a mate? You know, in other words, the psychological first aid is your mate, your friend, your sister, your brother, whatever. So, anyway.
Yes, so I think that's true. And do people know? People mostly know now, but they don't know uniformly. And not necessarily against a counsellor or a psychologist going in, but the question is what they're doing, and what they shouldn't be doing is anything more intensive than what they need to be doing. The critical part in this, I can't underscore it really enough, is that most people recover in their own way in their own time using their strategies. Now, we can bolster and support that, but the absolute no-no is to get in the way of what that natural recovery trajectory looks like. If someone's strategy is to say, look, you know, the way I cope with things is I park them. I park them on the side, I deal with them my own way, I get a sense of control back. Interfering in that, forcing someone to talk about or deal with something when they're not ready to, and in fact it's not you they would want to talk to, they want to talk to their spouse if they're going to talk about this event. We've got to make sure that we do no harm. And so psychological first aid is positioning itself about how to gently do what we know is no harm and support as people need it in the way that they need it, and how do you position yourself around that without needing to be a mental health professional. Oh, so the supervisor question. What the hell did you do that for? You know it's your fault. And not as uncommon as you might think when you're dealing with the aftermath of an event like that. So there's certain things that supervisors easily say that entrench a position. I told you not to do that, is being the first thing that comes out of their mouth, even if there is an incident that's escalated. And so how people then lock on to that and what it means to them. So there's, we don't need to be psychologists about it. We don't need to be health professionals about it. But there are some simple things about saying and not saying and things to look out for.
Sometimes you hear people say, you could have been killed.
Yep.
It might be badly killed or might not be, but does that cause?
It could go either way, but so that kind of statement wouldn't have been the worst that I would have heard. Let me tell you. Yeah, and I think half of my patients wouldn't have been patients if their supervisor had said that to them. Yep.
Okay. So, David, can I just ask, what does that mean for boards in terms of looking at their organisation's preparedness for dealing with incidents? So if I'm in a governing body and I now know that the reactions of peers as well as the reactions of supervisors are going to be important in predicting the trajectory, should I be asking at a governance level, well, how are we dealing with that in our organisation? What sort of training are we doing, etc.?
I think, yes, I would be. I would be asking about that. I think that given what we know about the influence of supervisors and managers in terms of support and not support and trajectories, I would be asking questions about, are our people trained? Are they confident about knowing what to do and how best to support? And without making everybody anxious about what that means, because these things are simple, they just need direction and common sense and direction, and
Very
training. Yeah.
Excellent. Okay, do we have any other questions? No, please thank David. That was a very interesting, useful contribution, David. Thank you. Now, we're going to move on for our final presentation before we do a panel session. And it's my pleasure to welcome, let's get my agenda back up. It's my pleasure to welcome Karen Crawshaw. Karen has worked in the New South Wales public health sector for many years. She's currently the Deputy Secretary of Governance, Workforce and Corporate in the New South Wales Ministry of Health, and she's going to give us an insight into the approaches being used in New South Wales. So thank you for coming down, Karen. We appreciate it and welcome.
Thank you. I'm just juggling two iPads because I came down from Sydney and I've got them on an iPad rather than in paper, and I'll just make sure I'm not doing it backwards. So, is it going? Yep. Yep, good. Okay, just making. Yes, okay. It is being temperamental. Are we going the right way? Yeah, it's back to front. Is it? Yeah, I thought it was. Yeah. Okay, here we go. Okay, thanks everybody. Yes, we're all wrestling with what is a very vexed problem of hospital violence. We've had quite a significant increase in attendances that relate to ice addiction and the unpredictability of people presenting at RIDs with ice in their systems. We've got the age-old problem of intoxication, and as you've probably read, we've had lockout laws and things, various laws that have helped in some pockets of Sydney, but obviously alcohol remains quite a challenge for us as well in our EDs. But what happened not last February, the February before last, is we had an incident in Nepean Hospital, and Nepean's in the western suburbs of Sydney. And we had a situation where a patient was brought in by police, he'd been arrested. He was then left by the police in the ED, and at some point, when you look at the footage, he wandered behind the station in the ED, pointed out by a registrar, helped himself to a pair of scissors to do whatever he was meant to be doing. I think he asked to borrow a pair of scissors. This is how laissez-faire the approach was. And the next thing we know, there's a registrar being taken hostage by him. He'd showed no signs prior to that of violence. And police were called, and both a security staff member and the police officer were shot with the police officer's own gun. So it created quite a storm in Sydney, and like all good government agencies, when you have a crisis, you have an action plan, and that's what we've got. We had a round table. The unions came out to express their concerns about occupational violence in health. We had a round table with the unions and a range of other stakeholders, and they agreed to this 12-point action plan. So I'll just take you very quickly through it, because I understand the focus today is preferably on what we're doing with our security staff. But basically, we've got we focused it on the EDs because you've got to start somewhere. When you actually look at our physical aggression data, and we actually collect physical aggression data across the system, about 40% of our physical aggression, and we define physical aggression as not verbal, but just a push, a shove, anything through to serious physical assault. When you have physical aggression, we have about 40% of our physical aggression incidents are in mental health units, anticipated. About 40% are actually on the general wards. So when we think about increasing dementia, delirium, managing that, about 40%, so it's about 40%. So it's quite a high rate on our general wards. Not serious in the sense of, injuries being sustained, but people being pushed and shoved, and I suppose starting to get inured to that idea. Well, this is life in my job, and about 12% in our EDs. So not such a high proportion, and then about the rest of it, about 8% in other environments. So not the highest proportion in EDs when you think about the extremely busy level of activity, particularly in our bigger EDs. But nonetheless, what we do find is that where you do get incidents in EDs, our more serious levels of injury were coming out of EDs. Again, not enormously high. When you look at our record of notifying WorkSafe or Safe Work New South Wales, we have about, over the last 3 or 4 years, we've had about 8 or 9 notifiable incidents. So that's where somebody's been seriously enough injured to have either a hospitalisation of some kind. But in that, most of them have come out of our EDs. So smaller numbers, but serious. We decided we'd focus on EDs, but we haven't left the rest of the system untouched. So looking at ED, our 12-point action plan for EDs, we've got multidisciplinary training of ED staff, and I'll go through these in a bit more detail, and you'll see then the various elements, and I'm happy to make these slides available. I won't go through all of them in detail. So one of the points in the action plan was doing a security audit. So what is going out there? We have some beautiful policies in New South Wales Health, but often they're, honoured in the breach. And so even though there's a requirement to have regular self-assessments, we were being told by staff that they were not always being met or being met with a degree of diligence. So we chose about 20 in a random sample of hospitals, ranging all the way through from our big fellas in the city through to smaller country hospitals and remoter environments. And as you appreciate, in New South Wales, we do have more of a challenge around the rural and remote. It is a very significant challenge for us, the rural and remote hospital settings where you don't have police on tap and you have to have minimum staffing levels. So that's a whole different ballgame. But focusing on our security audit and what came out of that, what it showed us was there was poor staff vigilance in respect to personal safety. So that incident I described to you in Nepean that kicked off our action plan, that was writ large across the audit results. People were just not vigilant about their personal safety. Doors chopped open that were meant to be security doors, people not wearing their duress alarms even where they were available and good. Some of the staff not having been properly trained or not up to date in their training, and just a general somewhat of a laissez-faire approach. Also, the design of some of our EDs could have been a lot better in terms of thinking about that workplace health and safety side of things, and that's certainly something that we've tried to beef up in future design of facilities, how you build in a more robust way that workplace health and safety assessment into the design of facilities. And we don't just rely on architects alone, but we now require a workplace health and safety assessment around the design. That's as an aside. So ED staff, as I say, not consistently trained. Clinical staff not understanding their responsibilities. So one of the issues we found, and it was certainly something that the Health Services Union that represents our security staff complained about, is that the clinical staff, even when they're dealing with patients, and by far the most violent incidents come from patients, not from visitors, mostly patients, was that often the nursing staff would be standing back and expecting the security staff to go forward and manage the aggressive patient. And that's not really how it's meant to work. I mean, at the end of the day, this is a patient, and this is a patient for whatever reasons manifesting challenging behaviours, aggressive behaviours, but generally it's up to the clinical staff to think about what's the best response and how to lead that response. So we needed to change that around and have our staff better understand the clinical staff's role and the non-clinical staff's role in managing the incident. Inadequacy of duress alarms. As I said, even when there were duress alarms, they weren't being worn, but nonetheless, some of our duress alarms were old, they were clunky, they weren't always working, and so it put staff off wearing them, or there was insufficient numbers of them. So one of the things we've done, since we've spent about $5.5 million in the last year on upgrading our duress alarms and bringing them into the 21st century. Improvements to layout, I've talked about that in the ED, and we've got a minor capital works program underway in the order of about $12 million to try and address some of these issues that came out of the security audit. I mentioned that we audited 20 and we put together a team to go and do that audit. Workplace health and safety experts, security experts, nursing staff formed the team. What we also asked to be done for the remainder of our 24/7 EDs is that they had to go through a self-assessment, and we looked at the results from the self-assessments as well as the results from the actual physical audits. Then generally, as I said, the risk assessments weren't as good as they could have been, notwithstanding our very good policies. So ED staff training. we had an excellent violence prevention management program. Excellent. 4 days long. How many ED staff are going out for 4 days? So it was very much focused on the mental health staff and well attended by mental health staff, and it's an excellent program. It's just we weren't capturing the ED cohort. So what we've done is we've taken the violence prevention program, we've picked the eyes out of it as far as usefulness for EDs is concerned, and we've brought it down to a 1-day course that can be delivered in 4 2-hour modules. We've got a train the trainer module out, a train the trainer methodology out around it. The staff can train on site, and they can train as a multidisciplinary team. So it's not the nurses going and doing it and then the doctors going and doing it, if the doctors go and do it, or the security staff going and doing it. They train together. So that's the object of the exercise, to get the multidisciplinary team working, the co-black teams working together, because that gives you the best response. So we've certainly upped our game as far as that is concerned. Also, in relation to training, we've also had to back it up with resources, online resources. We have a Health Education and Training Institute that services the whole of New South Wales Health, and the Institute has also included resources that can be used after the event to reinforce the training that's been done, refresher videos, etc. So, for example, I think in the Violence Prevention Management Program there are about 56 or so different holds and restraint mechanisms that are taught. We honed that down to the most commonly used ones in an ED, and so it's about 14. So we've really, as I said, targeted to the ED environment. Okay, talking about security staff. One of the issues that really came out of not just the audit, but out of the round table, was the concern about security staff, their role. We'd had over the years concerns expressed about their not understanding their role, concerns about their legal protections, concerns about being pushed to the front of the pack in terms of managing a response. So, and concerns that they felt like they were at the bottom of the food chain. So there are a whole raft of issues around our security staff. So what we did, we looked at how do we professionalise this group. And just to set the context, in New South Wales we have both security staff that are pure security staff. They all have to have a Class 1A security licence, but that's what they do, they're security staff. But we have another category of staff called a health and security assistant, and that's sort of a multi-function staff member that can do cleaning, ward duties, range of other duties, as well as security. So, and that cohort of staff has grown significantly in recent years because of the flexibility that it provides, particularly in some of our smaller facilities. But even in some of the bigger facilities, they've become quite a popular category of staff. They too have to have a Class 1A licence. But one of the issues is security staff are not bouncers. We're not running nightclubs. So we had to think about how do we make sure our security staff are professionalised and integrated into the health environment. So we partnered with our TAFE, and we developed a 3-day refresher course for all our security staff, both our health and security assistants and our full-time security staff. And we are in the process of putting all of those staff, notwithstanding they all have a security licence, we're putting them all through this 3-day health-specific TAFE course. The feedback's been great, and it just lifts the game in terms of how they approach patients, how they understand the environment in which they're operating, how they understand how they're part of a multidisciplinary team. Those health-specific issues, the fact that, you're dealing with patients at their most vulnerable time, you give them that context that you're not going to get if you join all the other people doing a Class 1A or whatever the equivalent is in Victoria of security courses and getting your ticket. So that's compulsory for all our existing staff, and then we're running the courses over we've run some last year and we're running more this year to make sure we capture everybody. In addition, from here on in, we are going to require that any new recruits go through the health-specific course before they can become one of our staff members as a security staff member. So we've made it, in a sense, a mandatory part of the qualification to be security in New South Wales. We've also recruited extra security staff because that's what you do when you have a crisis. You always recruit more staff. So we did recruit some more staff. But that's not all, let's be honest, that wasn't the main answer. The main answer was getting those staff that we had to work more effectively and getting the clinical staff to understand better how best to use the non-clinical security staff. Now, legislative change, I'll just quickly mention, we had some concerns expressed about, what do we do if we touch a person and, are we going to be charged with assault? Notwithstanding, we've never had anybody charged with assault, but it lingers and it's a concern. So we've done a range of legislative measures. We've basically made it clear that where a security staff member acts in good faith to either assist where they're dealing with the involuntary treatment of a mental health patient, or indeed the involuntary treatment of any person, for example, where they're not, the doctrine of necessity and then they're not able to consent, that they are protected from liability if they're acting under the direction of the medical or the clinical staff. And we've also given them some protections. Well, it's not so much protection. We've also made it clear that if it becomes an aggravating factor in sentencing where you assault security staff on our security staff. We'd had an aggravating factor provision in there for assaulting nurses and doctors and clinical staff. We made it clear it applied to all our staff, including our security staff. They were the main legislative changes, and in addition, they wanted some clarity around what to do with persons and what they could do where they needed to eject persons, and this goes beyond the patient treatment area, but where you do from time to time get people coming onto your premises, visitors or others who then start to engage in an unsociable way, and removing them. And normally we would say, we would normally rely on the police to come and eject them, but in those circumstances where we need to do something quickly, we've made it very clear that security staff, appropriately authorised security staff, can engage in that and eject the person from the premises. We have some provisions there around trespassing on hospital premises. So that gave our security staff a deal of confidence around their role and a degree of competence around their role. We've also talked about this strong safety culture. Hark back to the Nepean incident and the fact that we actually had a registrar who watched while this patient walked around and picked up the scissors and then wandered off into their room. And then think about the results of our security audit. Clearly our safety culture was lacking. It's terrific around manual handling hazardous chemicals. We've had great results, but this personal security aspect was not first front and centre of people's minds. So we've had, this is a work in progress, but we've got I guess you'd say a safety culture program underway. We've asked the unions to partner with us around that and make sure they're getting safety messages out as well to their membership. We're looking at opportunities for subliminal messaging everywhere we can. For example, on your pay slips. We're looking at little laminated cards that can go with your duress alarms. So all those opportunistic ways of just reinforcing that message about thinking about personal safety. And as I say, that's still a work in progress. Yep, okay, we're nearly through. Well, we are nearly through. So they're the main issues, and that's where we're at. As I say, it's a work in progress. We certainly haven't solved the problem, but we've certainly got a lot of activity going on, and I think we've made some good strides, particularly in the education, the training side of things, in the professionalisation of our security staff as well. I think they've been really positive rungs on the board.
Thank you, Karen. Might just have time for a couple of questions. Just one while I've got the floor. You've recently gone to a devolved model of governance with boards.
I don't know whether it's that recent. It's about 6 years old. It
Yes.
was the K-Rudd.
In the scheme of health.
K-Rudd
Yes,
exercise.
But most of this is you're driving a common approach across the state
Yes,
from
we
the
are.
ministry.
We are.
And so what do you expect of your boards?
Well, at the moment, it's not so much what we expect of our districts, how they personally arrange that between the management and the board. Our interaction is day to day with the management. Yes, we've gone to a devolved model, but we probably still have a more systemic approach in New South Wales than perhaps Victoria does. You're really devolved. We're devolved. And so we definitely have a system manager understanding of the centre and of the ministry. So we have a capacity to issue policy directives, we have a capacity to apply it, we can put it into our service agreements, but the Secretary also has a capacity to direct anywhere. So, and that's really what the expectation. I meet every month with the chief executives of our 15 districts and 2 networks, and we talk, and one of the items always on the agenda is the issue of not just workplace health and safety, but what's going on with the security audit. We, do the usual forming groups and making sure, and we'll be out, we've said we'll go out and audit again and make sure they're doing it, really. That's all we can do, just to make sure they're doing it.
Thank you. Questions from the floor? Yes, over there, thank you.
Russell Harrison from Western. I was interested, was there anybody looking at whether the police should actually keep their guns out of the ED or hospital environments?
Yeah, there's one of the pieces of work, if you go back to the 12-point plan, one of the issues obviously that stood out for us was how a police officer attending to assist ended up getting shot with his own gun. So there are, when you look at our policy, there are meant to be gun safes in hospitals, and where they're meant to be able to make safe their guns before they come on the premises. I do have to say our police were quite insistent in this era of, terrorism, that it's up to them to decide whether they put a gun in the safe or whether they bring it onto the premises. They were extremely strong about that issue. We have reinforced the issue around gun safety. They've done a review around that incident and how they can learn from that incident. Part of the 12-point plan has been we'd had an MOU with the police, health and police had had an MOU around management of mental health patients. And we've extended that MOU to management of aggressive patients more generally. And the takeout from that was the police not doing just their own risk assessment in isolation from health, and health not doing its own risk assessment in isolation from police, but where there is a need for the attendance of police, a common dialogue and risk assessment around what might need to be done. That was the takeout from that, and that's what we've done in expanding the MOU to include all aggressive patients, not just ones suffering from mental illness or mental disorder.
And that's at a statewide level?
That's a statewide MOU. Obviously, again, has to be implemented locally, and, you know, like anything, good relationships at the local level are pivotal, and good escalation processes at the local level are essential. So if you go around, if I visit hospitals, I'll come to some hospitals where they've got this fabulous relationship with the police, they've got good escalation processes where things have not gone as well, and they can sort them out. You go to some places where it's not so good, and it's usually because the escalation processes aren't great. So again, you've got to have those good relationships at the local level.
Fantastic. Okay.
Okay.
Thanks, Karen. Could you join me in thanking Karen for her contribution? That's certainly some common themes there, but very much added to the discussion that we've had today, Karen. So thank you again for sharing that experience with us. Okay, now we are going to move to our final session of the day, which is a little bit of scenario work at your tables and then a panel discussion around a scenario that's been created. I'm probably going to suggest that some of these tables might want to congregate into larger groups of fewer tables, because Tanya's got a case study for you. They're already on the tables. Okay, so I'm going to briefly introduce the case scenario to you, get you to have some discussion on your tables around this scenario, and we're then going to have a panel, and you can have a discussion with the panel about what your thoughts are on the scenario. All you need to do is just identify somebody from your table who might sort of take the lead in kicking off the discussion with the panel. So while I'm reading this, a couple of you might want to kind of move in this way from down there, and I'll just briefly go through this scenario. It's obviously fictional, but I think it'll ring bells with most of you who work in health services, regardless of where you work. It's developed to enable board members and chief executives to explore their role in leading the organisational response to prevent and manage OVA, which we now have abbreviated. It's about two nurses, Toby and Louise. Louise is experienced, a 10-year nurse. Toby has been working in a metropolitan service and has now returned to this health service in a small rural town, and they are the only two nurses on duty. There's a visiting medical officer and there is no police station in town, so they're quite isolated. Toby believes the organisation is very hierarchical, with a culture that doesn't encourage people to speak up. They've got a patient called Mark. He's 22 years old. He presented at 4 o'clock, accompanied by two friends. He's got, or thought to have, possibly a head injury, the etiology of which is unclear, and the medical practitioner admits him and directs neurological obs taken every 30 minutes, and that works well until midnight, when at 12:30 Mark becomes aggressive towards Toby, doesn't want to be disturbed to have his neuro obs, who would be. The other patients in the ward are disturbed. Toby asks Louise for assistance, and Mark then becomes aggressive towards both of them and tries to punch Toby. And Louise's thoughts at that point are, the police are a while away. I've asked for help before and I don't want it to look as though I can't cope. And we've got a ward full of other patients we've got to look after. So she decides that the best course of action is to let the patient sleep. So we just would like you to have a chat about that scenario, consolidate your thoughts at your table about what's happening here, and what issues it raises, and then we're going to have a small panel discussion about that scenario. So consolidate your tables. For the panel, I think perhaps you can organise yourselves up here at your leisure. We'll give you just, say, 5 to 8 minutes to talk about this, and then we'll have a discussion about it. Is everyone clear on that? Good.
The staff is, but we still have these sorts of problems. They know who you were. The same comment is that if you're, your chief executive of an airline, you should fly in the back seat of the last row of the plane. You shouldn't always sit in A1. Yeah, but that's most chief executives have never got past A1. There's a whole part of the plane back there that they've never seen. Try and run it on the line. Don't go to the lounge. Go sit in the all those things. It's part of it. Many chief executives. Maybe they were following the policy, which is to withdraw services, which is, making employees safe is the first priority. I think they've done the right thing.
The guy who we have might have a concussion because he's going to sleep. But it is not. They shouldn't just go let him go to sleep without reporting it and escalating it on some, perhaps the CEO or whether the representatives or whatever. Because they're just saying, go to sleep and let's forget it.
Yeah, and the chief thing might have to escalate.
No, but the CEO.
But the CEO
or whoever's on the hospital.
horticultural medical coverage outside of
Well, there's clinical issues there about are you capable of doing providing service in the first question, which I think, if we ignore the clinical stuff and say, well, that's it, but then you get down to this is supposed to be for occupational violence.
But I think a lot of it comes down to what is the governance around how those sorts of decisions are made when there's no medical person on site, so it's left to nursing staff. So, do they have... Well, there needs to be protocols. Before that, there needs to be... So what the board can be doing is, what are the protocols for after hours care in our urgent care? And, are we equipped to safely provide that care? And I think there are the sorts of things that boards need to be considering. So they can't get into the operational side, but they can say how do we deliver clinical care outside of ours, and what other parameters, what arrangements do they have with other hospitals.
Can I just invite the panel to come forward, and you can keep chatting for just another minute or two, and then we'll pull you forward with, together with the panel. Thanks.
Addressing the CEO, they should be also policy.
So if there's a couple of people, mind you, it says there's just two. One would assume there's more people on site than two. So if there's But if they've got this isn't an urgent care, is it? So if there's an urgent care, you'd expect there to be acute part of it as well.
Okay, let's come back together, ladies and gentlemen, and we'll have a bit of a discussion around that case scenario that you were given. I'd just like to introduce to you Gabby Fennessy, who's joined the panel. You might want to stand up, Gabby. We've got a bit of an awkward arrangement here. Gabby has got this marvellous title. She's the Acting Head of Insights at VMIA. So she was just saying to me, people come up to her and say at random, have you got any insights into this or that? But her job at VMIA is to look at patterns, I think, of claims and analyse them and feedback data. But I love the title. I'd love to be called the Head of Insights. And everyone else on the panel you've already met. So on my far left, we have David. Next to David, we've got Tony. Next to Tony is Denise. Then we have Alistair. And then we have Sue from Peninsula Health, and they've all spoken to you during the day, and then Gabby's joined the panel. So the purpose of this is for you to give us your insights into what you think, the issues you think this case raises, and we'll get the panel then to comment on them. So I'm going to pick a table to kick off, and I think I'll pick this table over there. So did you nominate somebody who was going to speak? Everyone's looking at you, Linda. Would you like to kick off with some thoughts based on the discussion of your table? And we might need a microphone, I suspect. Who's got the mic? Do we have a spare microphone? We've got two up here which we need. Do we have any more? Yes? Oh, great. Thank you. So the microphone goes to Linda over there. Oh, we've got many microphones. There we go, lots. Thank you.
Thank you. So in no particular order, the things that we talked about, so in regional and rural health services, this is probably not an uncommon situation, a small number of staff. no on-site security presence. We did note that there were earlier opportunities to perhaps foresee some problems with a patient with a head injury, noted at 4 o'clock. And I mean, obviously we've got limited information here, but in order for OBS every 30 minutes, there's no end time to that, or what's to happen to the patient if any of those OBS fall outside normal limits. We also talked about, so the patient has probably had 30-minute OBS for about 8 hours by that stage, at which time I think most of us would probably become a bit aggressive if we were still being woken up every 30 minutes after 8 hours. So it doesn't seem like a fantastic plan of care for the VMO who's then gone home. We also talked about whether there was capacity to call in other local staff, or if there was an executive on call to assist with backup. We also talked about whether the facility was actually an appropriate place for that patient in the first place. A head injury in a small regional hospital probably isn't an appropriate spot for them.
Okay, now I'm going to call a hold there because you guys have been very productive, and I want to leave some things for others. So we've got a long list of things, and I'm going to ask the panel to comment. One of the themes there probably is the appropriateness of the clinical management. Was it appropriate to admit this patient to a small hospital with that sort of infrastructure or lack of it? And was it appropriate to be waking them every half hour, 4 hours and hours, and where was the plan? Now, who's a clinician on the panel? Sue, I think that might land with you. Do you have a microphone? Can you tell us what you think about that?
Well, we were fortunate because Eastern Health actually has a hospital that has 2 staff in it overnight. So we had quite a long discussion about it, and the view was that a hospital of that size probably doesn't have the capability for that sort of patient. They shouldn't have been there in the first place. So clearly there was a problem with the assessment and the triaging of that particular patient.
Okay, other comments? Who else would like to comment? Tony, because your people would be called to move him on, wouldn't they?
They would, and I think, if I recall, he was dropped off by his friends, wasn't he? So that's a big issue in a lot of small rural hospitals that don't normally receive these patients, but will get them from the community. So I tend to agree. I think these are the sort of ones that those health services should very quickly identify a plan to move them on, have a conversation about that, and very upfront about what their capability is, in the sense of, we have staffing and other things, so that it doesn't find its way down the list of priorities within other cases with the ambulance at the time.
So does this mean that at a small rural hospital you should never accept anyone with a head injury? Is that the...
Well, it depends on location. So this is a complex issue around the state. So in many places, that's the health service that they really will need to go to for stabilisation as part of the normal system. But in many cases, there are a lot of small services that are not part of the sort of triaged by ambulance system, but which will get people coming in from the community and have to deal with them. Yep. And so you may not get them as part of the system, but you have to be ready that they may come in.
So if your paramedics were called to a footy match at, way back at beyond, and somebody had had a bit of a head injury and query concussion or something, would you bypass the local hospital?
It depends on the type of hospital, but
Depends
normally
on,
you would. The triage system, you normally would. The issue is often around, but in parts of rural Victoria and rural Australia, there are volunteers who probably it is the most appropriate place for them to go to their first highest level of care, just to at least be stabilised. But they're usually no one as that point.
Yep. Sue, thank you, Tony.
I was just going to reiterate or say something very similar to Tony, that I think there needs to be the government's already doing a capability framework review anyhow, and I think a whole lot of things will fall out of that. But I think small health services need to recognise their limitations and up transfer as quickly as possible. Okay, so we have got the question of the patient being exhausted. Does anyone want to comment on that? By half-hourly OBS for hours and hours and hours, and just... Of course they'd be exhausted, and of course they'd be angry.
Yes.
Somebody should have called the doctor much earlier to try and get a review. So it says something about the culture that people aren't prepared to escalate issues. So that's something that needs to be addressed. But, one of the things we learnt from the Safe Wards program was the patients tell you everything. We know everything about the patients, but they know nothing about ours. And how do we put some context? At least we should have explained, or they should have explained why they were doing neurological OBS, to put some context around that.
Excellent. From a VMIA perspective, Gabby, do you see that sort of this kind of picture coming through from time to time?
Yes, we do, especially walk-ups to urgent care centres, where there, I suppose, is a will to really tackle some of these patients rather than escalating, transferring on, and perhaps not so much stabilisation and referring out. So it's fairly interesting as well. But it does happen quite often.
What would anyone from the regional hospitals like to comment about your ability to accept these patients? Or yes, over there, thank you. Can we grab a microphone down there? Thanks.
Cheryl Clutterbuck from North East Health Wangaratta, but in my past life I worked at Alpine Health, Mount Beauty, so we had a lot of ski injuries that would come down with head injuries. What we did have was a very supportive GPs that would be in there at the drop of a hat. Now, not working there anymore, but now they've got e-health, so they can actually dial in to a bigger hospital and be reviewed by a registrar there. That registrar can then look at the picture, look at the patient, the whole thing, and can organise for the ambulance to come and pick up.
Fantastic, so they can get that support. Thanks for that very much. Okay, now there were some other issues there about lack of security, but we might just keep going through round through the tables and see what others thought, and perhaps these issues will come back. If not, we'll come back to them. So let's go over to your table. What was your discussion around this?
Similar to what you were saying, but perhaps just 3 more points we throw in, is that there doesn't appear to be an escalation policy in place. This is going a bit pear-shaped, and, you know, the staff have been left out to dry. We're very concerned around Louise's mindset and what support she's been given in the past, if any. And we're also looking and querying what sort of orientation did Toby have when he first started working there.
Yep. Okay, so let me think, David, perhaps we might ask you just to comment on that. So Louise has basically said, I'm leaving the patient to sleep. I'm effectively not going to follow the doctor's request because of the situation I'm in, and there's a reluctance to go for more senior help.
So, I mean, that was one of the things that jumped out at me when I read it, really, which is around the culture within the organisation in relation to the preparedness to ask questions and ask for guidance and help. And it does kind of give us some indication around the degree to which perception or reality has been that asking for help and guidance has been something that's been reacted to either negatively or not supportively. So the issue, you know, what jumps out at me is you'd be asking questions around the culture of the organisation.
Yeah. So if you're a staff member and you come to a new hospital and you think there's a culture here, and you're a brand new nurse, and you see what you think is a hierarchical culture that doesn't encourage you to ask questions, what can you do? What should you do? Can anyone respond to that?
Well, I mean, I have my ideas, but I'd like to know how the hospitals would view that, really.
Yes.
I mean, there's how we'd like to do it in a perfect world, but then the question about how the hospital would respond.
Yeah, so what would you do as a junior nurse if you're in an environment like that? Sue?
I would call the exec on call.
Right.
You know, if you've got the right culture, you should be able to call your executive on call.
Yes.
And if the exec on call doesn't respond or you don't feel comfortable about that, you should switch to put you through to the CEO. You shouldn't feel worried about doing that.
Yes. Okay, so you're saying to these staff, be tough. You're a first-year nurse and you're worried about the hierarchy. You think there might be a bit of a block, but give it a go anyway.
No one's going to yell at you if you make a mistake, but they're going to be disappointed if you didn't escalate something that should have been escalated.
Then you're not going to get into strife if you make a mistake. Do we all agree with that? You shouldn't, definitely shouldn't, yep. But if you don't escalate and it goes pear-shaped, you may well be in strife. Okay, Gabby? Yep.
I might suggest I would agree with that wholeheartedly, that in reality, there's probably a gap between that and what exists out in the community in terms of staff actually feeling the comfort to be able to do so and be responded to in a way that we might expect.
Yep. Gabby, did you want to comment on that?
In the moment, I would hope that they'd at least call the VMO as the next line of contact in that situation if they were too frightened to talk to executive, but would probably bring it up with my unit manager the next day or next shift to have a discussion about it.
Yep, fantastic. Alistair, from your perspective?
Yes, just from me, I guess, this is one of those things that's a bit of a free lesson. So we have a situation where there's broadly 2 possible things that could have gone really badly wrong. One is the punch could have connected and caused some serious damage. The second thing is that the observations couldn't have been done and the chap could have fallen into a coma or whatever else and had some negative medical outcome. So we want to prevent that sort of thing from happening in the first place. So the fact that it didn't go badly doesn't mean it couldn't have gone badly. So our systems really need to be in place so that we can actually deal with these issues. Now, the second part of that, I guess, is the investigation side, which we might come to later. But ultimately, what we want to be doing is ensuring that we have the systems in place to deal with these things so that we don't get to the situation where it could have gone bad and we're just lucky, you know, by the grace of God, so to speak, that it didn't.
Do we know what the outcome of it was? It may have gone bad, actually. We don't. Yes. So, but we assume that it was just that he simply went to sleep and it all went through. I mean, it's possible that his aggression was related to a developing neurological condition. Yeah. Denise, comments from you?
Yeah, look, from a department point of view, and I'll just go back to my presentation and really plugging the framework, and really from our point of view is that we actually want health services to look at the framework, to assess their capability and systems, their current systems, to actually measure what reality and kind of ideal might actually be, and use the tools that we're providing and others are providing around the room and your shared learnings across the system to actually work through what strategies would work, whether you're a small health service or a large health service. But using that framework, we think, will help you understand where there might be some gaps and where you might be able to actually put in place some systems early to try and think about, you know, how do you actually promote the idea that you can call exec on call, you know, you can actually call it out when you're concerned, and how do you start to build that culture? So from us, you know, it is very much around, as a department, what we can do to support you to do that, but locally we need boards and management to really take on board a very visible approach to actually saying it's not acceptable here, we are taking it serious, we are doing something about it. And, you know, and for junior people coming in, you can raise the concerns.
Denise, the approach that Karen talked about earlier was sort of different in New South Wales. I suspect it was much more centralised, much more directive and more perhaps compliance-based. And I just wonder if you've got any comments about that. Is there anything that our department is likely to be moving sort of more towards assurance and accountability at that level?
Oh, look, absolutely. I mean, you know, I think the reality of devolved governance in Victoria is the reality that we live in, but certainly the expectation of government around kind of compliance and assurance is becoming much more sort of focused, and our expectation will be absolutely around performance management going forward, that this is an issue that we will be kind of in the spotlight and looking at and raising as we go through the kind of processes around kind of how organisations are performing, not just on your financial, you know, kind of compliance, if you like, and your performance, but also on the issues of culture more broadly.
Thank you. Now let's come over here. Yes.
Gabriel Kirby from Hepburn Health, and we run very similar.
Yes.
So let me just be a little bit political, if I may. And I should have asked Karen, was it from New South Wales?
Karen, yes.
Yep. How many small rural health services are in country towns where there aren't police 24 hours a day? Because let's just say this scenario did progress to being a OVA, and we've got hospitals in towns
Yes.
where there are no police.
Where there's no on-site police. Yes.
When they took out that service away,
Yes.
our staff became worried.
Okay, so that's a real issue, a live issue. Yes. Does anybody want, I don't know if it's anything anyone on the panel can comment on, the important, yes, Tony?
I think that's the reality of the world we're living in, and I think the important thing is that you plan for it, because the likelihood of getting it returned is low. But the reality of that's now our environment, and we experience the same thing with paramedics in those towns, exactly the same thing. And I think what we often find is we work very collaboratively because we find solutions to those things. So I think for these are great case studies in essence of local health services, ambulance services and others saying, well, we're going to be exposed to these like we are other types of cases. How could we potentially work together? Are there things that we could do that might be different in that town, but they actually deal with the local issue? Because I agree with you. I think the worst case is if people go, we've lost our police, or police aren't there, but we've not built a system in place to acknowledge that, and it may not be perfect, but it's at least acknowledges the environment we're working in.
So that'd be about building relationships with the police in the regional town who are now covering, presumably, these small...
There's not much pointing through an arrow.
Yes, yeah, fair enough. Okay. Yep, we'll take that. No, I think the point's clear and well made. Yes, and they should be asking, yes, those questions. Okay, let's go to that table. Who was going to speak on there? Did you come up with any issues that haven't previously been raised? Over to Julie.
Well, yeah, the policies. I mean, we don't actually know what policies exist, do we? Or what escalation procedures exist. So, if I was a board member, I'd like to understand that. But I think what I think is quite troublesome is if you are a board member and say you don't have this case study, how would you know what's going on?
How would you know what the culture was? How would you know? Yes.
Which is really the point. You know, we don't usually have a case study.
Yes.
Like what is actually going on there?
Yes, so if you're sitting on the board of this health service, and not knowing about this case study, what sort of questions should you be asking as a board member of a small rural, Sue?
I think executives and boards, particularly boards, learn a lot just by walking around hospitals. You get a feel for the culture, you can tell if the people are engaged, they're happy or not. If they are concerned about their safety, it'll be pretty evident in their demeanour. So it's really important that boards walk around their health services and see what's going on.
Good point. Other comments about what the board should be asking for?
Yeah, a couple. From a systemic perspective, I think you need to have something in place. Now, for argument's sake, if you call that a due diligence framework, something which actually drives the board to exercise due diligence. Now, that's not going to help with the things that aren't reported or the things that are underreported. So it goes hand in hand with what we're talking about earlier with safety culture and systems and everything else. But you need to place an onus on the boards, and the boards need to place an onus on themselves to understand what the hazards are, to understand what the risks are. Not every detail about it, but understand broadly what there is within that work environment, and to understand how they're controlled, to have incidents raised with the board and escalated. And we heard some of the things that are happening at various health services about that today. So the boards and board members need to have, and indeed they're obliged to have under the legislation, an inquiring mind about these things and to take proactive steps to understand them. The walking around the hospitals, I think, is a wonderful idea. One of the things I always tell people to do is some form of safety observation where they're on the ground. And I've said this to boards of, some of Australia's biggest companies, that they need to do exactly the same thing. Get out on the ground and talk to people and understand what it is that's going on. The other comment I just wanted to make briefly, going back on something we were talking about earlier with the lack of police services in certain towns. I think in circumstances where you do have that lack of immediate assistance, it actually requires a greater degree of planning and other controls to be put in place because you don't have, I won't call it the easy option, but you don't have the option of immediate assistance. So that actually suggests that you need more controls in place. And as CEOs and boards, one of the things you need to be understanding is, okay, well, we know that we don't have a police service that we can call on immediately. So what do we have in place to manage that? And as other hazards and risks arise, we need to know through looking at our risk registers or however we do it, okay, well, are we actually managing that appropriately? Is there more that we should be doing? And what about our particular circumstances is different, such that we need to have a greater degree of, or a greater level of controls in place to manage it.
Thanks, Alistair. David?
And I guess coming from the mental health side of things, how would a board to be able to make judgments around that? So one is around organisational climate and culture. We would wonder about, in addition to the suggestions that have been presented so far, you wonder about metrics that can be used around psychosocial safety and organisational culture and the potential for organisations to be engaged in those in an anonymous way. The other parts are around asking questions around training for managers and supervisors in the degree to which they've been trained in how to support staff in the potential for and in the response to critical incidents and in de-escalation strategies and self-management strategies.
Yes, good. Gabby, anything from you from VMI?
We talk to boards all the time about questions they should be asking, especially through their working groups with Audit and Risk Committee, etc. Our expectation would be that you have a regular calendar with your board meetings and committees that talks about occupational violence, work health and safety, where there are reports. There should be a cultural piece several times a year where you get feedback from the organisation on cultural indicators. I mean, this place obviously has a poor reporting culture, so you'd have to potentially challenge the organisation about what they feel their reporting culture is. This could have been reported in several ways as a near miss. It could have been done as a patient safety issue as well. So there's many ways in which you could have captured this information if you had a good reporting culture and an inquiring organisation.
Thank you. Denise?
I just feel I need to mention WorkSafe as well, and the fact that they also do board training and are more than happy, and I've heard Claire mention it on numerous occasions, more than happy to have conversations with boards around what they can do. So there is one WorkSafe person there, and you know, making kind of giving them an insight into the sorts of questions that they should be asking as well. So.
Fantastic. Okay, Julie.
Just another point is to look at compliments and complaints. So I chair the clinical care at Moreton, and we've had complaints but not compliments. So we're actually working on getting that coming through. The other thing that happened the other day, which I don't recommend, is that I hit my hand with a hammer and I ended up in urgent care. So I actually had first-hand experience of the care. And I must say it was very good at Moreton Hospital, but I wouldn't go to that extent.
To try and get you, for all the board directors to get personal experience. Thanks, Julie. Over on this table, is there anything that came up from your discussions that hasn't been raised already? Training, yep. And so, yes, and you've got two people here who are quite uncertain in their role, obviously. Yep. Yep. Comments on that from the perspective of the panel? Tony?
I mean, I can't say too much about the issue of training, and ideally training that's built on the experiences. So the case study we're talking about today is a great case study that I would suggest most small health services may not have experienced, but the fact that they know one that does, and talking to them about what's happening in your place and what have you learnt, allows you to then say, can we plan, how would we plan for this in our environment? And, you know, the concept of, well, if we just unpack it and talk about it, people go, well, you know, what would we do differently? How would we set up? What are our policies around this? These sort of cases, particularly it's the near miss, even if it's not yours, it could be someone else's in a like health service that you can learn from, and that they then become a really good framework to then say, so what are the, as David said, what are the capabilities you require to basically to do that? And as we talked about, we've done some immersive training, but there are so many simple training programs you can do that are actually, you know, focused about just understanding role and what would you do, even desktops and things like that.
And a couple of the presenters today talked about the importance of multidisciplinary training, so making sure that all the clinicians are involved, and potentially clinicians from outside the organisation, such as the paramedics. Any comments on that from perhaps you or David? Just how important is it for people to do multidisciplinary scenario-based training, as well as perhaps, you know, computer-based sort of compulsory things?
I think it is very important. Can I deviate onto something else though? Because we've talked about near miss. Unless I misread that scenario, this patient tried to punch Toby?
Yes.
Now, I know he didn't connect, but from a psychological perspective, that's not a near miss.
That's an incident.
That's an event.
Right.
So, and I'm struck by, you know, we need to keep this in our... We don't know what Toby's had happened to him before.
Yes.
So I think it's really important to keep in mind that threats and attempts can be events as well.
Actually, that's a really important point, isn't it? And do we have a common language about what is an incident and what's a near miss? Yep. Maybe needs to be hugely variable. Okay. Thanks for that, guys. Now there are two ladies down here. Did you come up with anything that was in addition to what we've talked about? It's hard being last, because there's sometimes not a lot left.
I guess just one observation would be the frame of reference that the long-standing nurse brings to it, and she's probably a permanent night duty staff member who doesn't see the board, doesn't see the CEO, doesn't get invited to education. And so we actually have this workforce that have a lot of responsibility that are often missed.
That's a very good point, and maybe we'll just go along the panel and ask for comments in response to that, or any other comments that you'd like to make about the scenario, perhaps again starting with you, David.
Yeah, I think that's a really important point, where there's often a range of staff who aren't necessarily participating in the kinds of workforce development programs that we might think about, and being able to be crystal clear in our minds about the breadth of what our workforce is.
Yes, thank you. Tony?
I agree, and I think for me, you can. So I go out one day a month with our crews, including night shifts. So you can choose to do those things. They're choices executive make, and it's amazing what you learn when you're going out with someone on a Saturday night in the middle of the city about what their experience is, and you can't unlearn that. So once you've seen it and see it, the reality is you sort of then got to do something about it.
Yes, good point, Denise.
Yeah, I'd probably just say two things. One about the training and the fact that we think from a department point of view that nuancing in training is really important. So a few people have spoken about it today, about the need to actually ensure that what we're training is actually conducive to the environment in which those people are working in. So, a 4-day training program, designed at mental health is not necessarily going to be, suitable for ED. So how do you actually accommodate individual training needs? We think prior recognition also helps in terms of making sure that we're not requiring, and particularly in the Victorian system where we've got lots of health services who have quite often multiple training programs depending on where you work and how many sites you might work at, being required to actually undergo all of the training for all of the services that you work in. So our approach is really about trying to standardise and be more consistent with the sort of training principles. So I'm trying to just support that kind of theory of getting training across the board, but not making it too onerous to kind of health services and staff. The other thing about the multidisciplinary thing I just wanted to sort of circle back on was around the fact that it's not just clinicians. So the idea of actually making sure that our health professional staff and our security staff are actually in training together around how they actually respond to these sorts of situations is important, because again, it helps understand role and responsibility. So, often it is just clinical teams getting together and thinking about how would we respond, but actually involving the security personnel in that is also important.
Thank you. Just brief final comments from the last 3 panel members.
Just on the night shift point, it's a really good point. One observation just from another industry, talking about the mining industry and particularly underground mining. One of the things that clients of mine found over time was, because the general manager wasn't there at night, the manager wasn't there at night, the superintendents were there at night, so you had supervisors and crews, and they'd typically go, well, we're just going to do it our way because management's not here, so we can do that. So to fix the increased level of safety incidents we're seeing at night, and I appreciate that part of that was fatigue, the general manager used to just turn up at night time in the middle of the night every now and again to see what was going on. And all of a sudden, you saw incident rates drop and compliance with procedures lift very quickly.
Thanks, Alistair. Sue?
We bring on permanent night duty staff onto day duty 2 weeks a year, and we think it's really important they get all their training, they get up to date in terms of what's going on in the organisation, but the people that rotate onto night duty get some insight into some of the issues that the night duty staff have to deal with.
Yep, very good. And Gabby,
I would
final
say,
word.
Bobby, basic competency would be escalation of care for all shifts.
Yes, good. Okay. Well, that's been a really interesting discussion, I think, hasn't it? Thank you, all of you, for your contribution to that. And please join with me in thanking the panel for theirs. Can I say from me, thank you all for your participation during the day. I've really enjoyed the day. I've learnt a lot. I'm sure that everybody here has learnt a lot, and everybody who's joined by video conference hopefully has enjoyed that experience as well. So thank you all very much for being a great group, and I'm going to hand over to Denise, back you come, to just do the final wrap up. But all the best to all of you in your efforts in this really important area of workplace violence and aggression. So thanks very much.
I had notes, but I'm not going to take them because everyone wants to go home. So I do just want to say thank you for coming. I will just remind you about resources available on the website. So please go and see that website. It is actually live at the moment. It's a developing resource for your staff and for yourselves. And if you've got any queries, questions, follow-up questions, the team of Janelle and her crew here, but also always available on that email address on the slide pack. I understand the slides will be made available, so we will send you that so you've got contact details. Thanks for your attendance. Don't forget Staff Forum on the 30th of June, and I'd just again like to say thanks to my team for making the day work, and also to Heather for facilitating the day, so thank you.